It's my understanding that you are going to be introducing a saliva-based test for COVID-19. When and how successful do you believe it will be in determining whether the virus is present in the person who takes that test?
Yeah, so we've already released the test. We got our EUA approval last Friday, and we've been running the test from the time we had submitted our data packet for review to the FDA. We feel that this is a big difference compared to swabs, given that the collection is easier. It does not put a healthcare professional at risk. It saves PPE. It can be done in a couple of minutes. The collection device is not unlike the device that's used for some of the direct-to-consumer genomic applications people have been using for a long time. The biggest difference is we're collecting 2 mLs of saliva versus what you get on the end of a Q-tip. So just the amount of material alone leads us to be able to detect more virus and more sensitively.
When you speak to health professionals on the front lines, they'll tell you there are plenty of false negatives and false positives in terms of at least the swab tests. Do you feel like your test is going to be more accurate than what we're currently seeing?
I think a lot of the tests out there are accurate. The data that's being reported with false negatives is not data from patients being presented or tested on the same day. What I've heard and seen is that someone has symptoms, they get tested, it's negative, a day and a half later, they feel terrible still. They go and see their doctor, they get tested again, and it's positive. Everyone's infectious journey with COVID is different. We've seen patients that are very, very sick that have lower viral load than a patient that might be complaining of a headache. So, repeated testing, I think, is what's going to be important when we talk about getting people back to work and monitoring this with respect to viral shedding and whether they're infectious or not.
How quickly can you ramp up the testing? What are the numbers that you sort of see potentially being able to reach in terms of this saliva-based system?
Yeah, it's a great question. What the saliva collection does is it enables more tests to be collected every day in a safe way. And where the next bottleneck will be back to the lab. So access to reagents and instrumentation will then potentially become the limiting factor. The samples are stable in the preservation agent in the saliva solution, but people want to know, and we have to know in order to be able to make some healthcare decisions. We got a call from the White House after the EUA approval asking those exact questions. What hurdles, what barriers can we remove to make sure there are no bottlenecks downstream now that we've alleviated one big problem? And immediately after that, we got phone calls from some of the largest life sciences companies in the world asking some of the same questions. Obviously, they understand the issue. And now we're all working together to make sure that those reagent instruments are provided with the government's support in some areas to increase capacity.
So as far as I understand it, Dr. Brooks, the FDA is still saying that this test should be performed in a healthcare setting and under the supervision of a trained healthcare professional. Is that the case? And if so, then how do you serve companies that want to buy a lot of their tests and administer it to employees in their own homes?
Right. So, a lot of people are interpreting healthcare setting and supervised collection in many different ways. Certainly, there are a lot of telemedicine companies out there that can meet both of those requirements in their understanding. But the FDA has been very clear about home testing and self-testing, which this is not, but they've expanded that to include home collection. So we're working with the FDA now, and we are submitting data that, after being reviewed by the FDA, will allow for home testing. Certainly, we wait on their review and their comments and their approval. But once we provide some data around the safety associated with collection and the stability of the sample, we think that we can work together in a short period of time to get kits into people's homes. It will certainly have to be physician prescribed, physician reported. There are many platforms that can do that, but that's how we're going to do it. Once we get that FDA approval or that EUA extension, these devices will then be able to send to people's homes to get companies tested, to get them the data they need to get back to work.
We just keep reading, Dr. Brooks, about countries like Germany and South Korea and Iceland that are putting mass testing at scale. They're being praised for doing it, and they're getting this virus under control. I don't understand how we talk to so many companies like yours, where there are 300, I've counted at least, test developers working on these kind of tests, at least 34 emergency use authorizations from the FDA, and yet we have such limited testing capacity in this country relative to Europe and Asia.
I don't disagree. I think as a community, we were not prepared. In fact, our lab is doing this kind of testing. This is not our regular business. We have turned our entire lab, 200 technicians, all of our resources towards contributing here. This was not our core business a month and a half ago. And I think that that's going to require other labs to do the same. Also, the testing for something like this has never been considered at scale. When we developed our approach, we made it such that there's nothing proprietary. They're all individual commercial partners, and we built that platform. What we've done can be rolled out in any clinical lab or commercial lab, and we're happy to help them, and we're fielding lots of calls in order to grow scale, not just in our own lab, but across the country.